right, good morning, everyone. Good morning to those who are with us here at St. Joe's in Miller Amphitheater and to those who are logged on from home or office. So it's my pleasure this morning to welcome all of you. And we'll start off with a land acknowledgement. We acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee Nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And without any further ado, I'd like to introduce, to many of us, he needs no introduction, Dr. Rick Ikesaka. He's going to be speaking with us today about upper extremity and line-associated deep vein thrombosis. So Dr. Ikesaka is an assistant professor in the Department of Medicine at McMaster University. He completed his medical training at the University of Manitoba and completed his residency in FRCPC certification for internal medicine and hematology at the University of Ottawa. He also has completed a subspecialty fellowship in adult thrombosis medicine and holds an MSc degree in epidemiology from the University of Ottawa. His research interests involve upper extremity venous thromboembolism and thrombosis risk of bariatric surgery patients. He is a successful applicant to the CanVector pilot trials competition, which funded the completed pilot Trimline RCT investigating low-dose rivaroxaban thromboprophylaxis in cancer patients, and was a co-applicant on the recently funded CIHR grant for the full-scale Trimline randomized controlled trial. He is also our hematology and thrombosis head of service here at St. Joe's. So without any further ado, Rick, take it away.
Thank you. All right. So thank you everyone for allowing me to present. It's been a long time since I presented in front of a live audience of anything, so it's nice to be back. Without further ado, I'd like to start and present this rounds on upper extremity DVTs and line-associated thrombi. So conflicts of interest are listed here, and I may talk about some off-label uses of medications, but you'll only be using the generic names. In terms of the learning objectives of this rounds, we are going to review briefly the upper extremity venous anatomy and to review the presentation of upper extremity clots, as well as the difference in risk factors and pathogenesis as compared to other types of blood clots. And lastly, talk about treatment and management and diagnosis of these types of thrombi. So essentially, the venous thromboembolism of the upper extremity accounts for about 4 to 10% of all venous thromboembolic events, but are much less studied than other types of clots, such as lower extremity DVTs. The types of patients that are often associated with these are associated with thoracic outlet syndrome or structural abnormalities, malignancies, or the presence of a central venous catheter or pacemaker wire or some sort of prosthetic device. It is expected that this type of clot will become more prominent or more common as time passes, as people are getting older and more people are receiving chemotherapeutic regimens that require long-term line or port placement for supportive care. I wanted to quickly review the anatomy and what we're talking about. In general, we are talking about the deep veins of the arm, so including the axillary and more proximal. We often see clots reported on ultrasounds involving the basilic and cephalic veins, often associated with PICC placements. These are superficial veins and are not the focus of this talk. We will talk briefly a little bit about the brachial vein because there is some controversy about this, as the general guidelines suggest treating most of the deep vein clots, but brachial vein clots are somewhat controversial, but we will go over that in short order. This area of the neck involves many of the major veins, arteries, and muscles that keep our neck and shoulders operating, and can be prone to mechanical compression depending on people's individual anatomy or slight variances. And with this can cause mechanical trauma, increasing the risk of clots. As we recall, the Virchow's triad does discuss endothelial injury as one of the major factors leading to blood clots or coagulation, and therefore this can be one of the inciting factors. In terms of presentation, many of you may have seen a swollen leg, or unilaterally so, maybe less so arms, though with our ICU population, this is a fairly common incidence. This just shows an image of discrepancy between two arms. The presentation is very similar to a lower extremity DVT in the grand symptoms in terms of arm pain, swelling, redness, discoloration. One of the peculiar findings can be a presence of dilated veins across one half of the chest as the blood tries to find an alternate pathway back to the right side of the heart. And occasionally these will present and be diagnosed when a central venous catheter in place malfunctions. You are no longer able to withdraw upon it or infuse medications, which will lead to some investigations. In terms of diagnosis, people have tried to generate well score type predictive algorithms in order to determine who actually needs ultrasounds or who needs further investigations. There really only has been one attempt, and with mixed success, I would say. Constance in 2008 did create a score which allowed people to be sorted into low, intermediate, and high risk groups, though most of the patients still ended up in the high risk group using this score, so would only have saved less than 30% of the ultrasounds. And when it has been validated, it has come out with a sensitivity of around 78%, which is a little bit lower than we would like for being able to rule out a DVT in the upper extremity. As such, it's just one piece of the puzzle, but it has not really been used commonly to determine whether or not a clot is present in the arm. In terms of diagnosis of this type of clot, ultrasound remains the mainstay of therapy. The clinical decision rule previously mentioned is at the top, showing that sensitivity. D-dimers perform very similarly to lower extremity clots in that they are highly sensitive, but generally useless for specificity reasons. And the compression ultrasound does show into the high 90s sensitivity and specificity, meaning, and given that these are without radiation for ultrasound and without any invasive angiograms, has become, again, much like lower extremity DVT, the standard of care, a standard of diagnosis. Currently, the guidelines have suggested that for a low pretest probability event, you can try using the D-dimer assay to rule out a clot, followed by a duplex ultrasound if it's positive, although this is based on low quality guidance. And for high pretest probability patients, much like in other types of clots, you should proceed directly to the imaging because there's no clinical or biochemical way you're going to be able to rule out a clot in this context. Overall, compared to leg clots, it's suggested that these upper extremity clots are less severe or less likely to result in pulmonary embolism, with 5% of them leading to pulmonary emboli, and with a recurrence risk of about 8% at 5 years. The proportion of people that do report some long-term symptoms, post-thrombotic syndrome being persistent swelling, redness, or other heaviness to the arm, skin changes, is about 19.4%, which is pretty high. And it's a little bit difficult to compare these numbers to leg clots because the types of patients that develop these clots are very different. And so it is possible that this recurrent clot risk could be either higher or lower, given that we are enriching for a cancer population. A lot of the upper extremity clots are either very sick ICU patients or cancer patients, both of which have a really poor prognosis overall compared to the general population, as well as a much higher bleeding risk. So I have a couple cases for you. Basically, this is a 27-year-old healthy person who presents with left arm swelling for a couple of days with no obvious other risk factors, non-smoker, no testosterone, no known thrombophilias, with an ultrasound showing axillary subclavian clot in the affected arm. And I proposed to you asking what the frontline treatment would be for this kind of clot. Now, admittedly, this type of rounds is not super amenable to getting feedback, given that I'm in a hybrid format. But if anyone in the audience wants to shout out, I'm free to take their opinion. Everyone's shy. Sure, fair. DOAC. So we'll chat a little bit about that and go forth. So at the moment, there is actually no randomized control data available for initial treatment of upper extremity DVTs. All of our anticoagulation plans are extrapolated from studies on lower extremity clots and cohort data that we have on patients that have lines in cancer and upper extremity clots. Currently, our cohort study is using anticoagulation for axillary and more proximal clots, include these ones, which the older ones you'll notice use particularly low molecular weight heparin bridged to warfarin, as that was what was more available at the time. And as people have gotten more comfortable with direct oral anticoagulants, a couple of studies have come up afterwards using these in upper extremity clots, though the clot research for DOACs in this population has really skewed towards cancer patients with lines inserted, noting catheter 2 and catheter 3, which is currently still enrolling. Overall, the recurrence risk is not high, and bleeding rates have been acceptable, with the exception of the catheter 2 trial, though we can debate in that cohort that bleeding risk, whether or not it was related to intrinsically the DOAC, or whether or not that was just related to a very sick cancer population, because we cannot compare that bleeding rate against the other trials because they didn't have cancer. We're currently at an interesting place where previously the ACCP CHEST were providing the guidelines for thromboembolism guidance, and slowly it's been transitioned over to the American Society of Hematology. And as such, some of the guidances are written differently or have not been updated in a long time. Currently, the guidances for upper extremity clots do suggest using an anticoagulant in this context, although they do not mention DOACs because these guidances came out before they were commonly used in cancer patients and in other types of patients. I'm going to talk a little bit about brachial veins. So this is sometimes reported on your ultrasound studies and is technically a deep vein, though exactly what to do with it is not exactly clear. It was not included in any of the guidelines as terms of what needs treatment, as they all comment on axillary or more proximal DVTs in the upper arm. And this is a very small caliber vein that is of unclear significance. There's a lot of practice variance among the specialty in terms of whether or not these actually do deserve to be anticoagulated, though recent expert consensus has suggested treating them if they are quite symptomatic or associated with a ongoing or high risk factor, notably like the presence of a catheter, central venous catheter, or a malignancy, and the patient is not high bleeding risk and at risk of suffering a complication. In terms of thrombolysing these, again, no obvious randomized controlled trial evidence, and subsequently our evidence for using thrombolysis in pulmonary emboli and lower extremity DVTs has thus far been somewhat disappointing, in that it has not really led to any improvements in long-term outcomes, reduction in development of pulmonary hypertension. In the most recent study, ATTRACT, for lower extremity thrombolysis in large iliac clots, there's a possible trend to improvement, but overall the study was negative for meeting its primary outcome. So really at this moment, it's still reserved for low-risk bleeding patients, generally young people without comorbidities, who have a very large symptomatic clot and that either are not responding to standard therapy or have a very strong predilection to trying to avoid post-thrombotic residual symptoms that may persist. In terms of using thrombolysis, we don't really have a lot of long-term data for arms, except for one study, which did suggest that for any degree of post-thrombotic syndrome, about 12 to 25% of people can be left with this if they do go with aggressive therapy, which is a reduction from people that just receive anticoagulation. But there's been some debate as to whether any post-thrombotic syndrome is a relevant clinical outcome, because any post-thrombotic syndrome can mean just a tiny bit of swelling at the end of the day, which may or may not affect people's quality of life or morbidity. And so whether that change is relevant for an intervention that has a confirmed and definite bleeding risk of, on the lower end, probably around 5 or 6%, and in certain populations higher, particularly older populations, this is not clear as to whether or not we should be using this more often. Generally, we have not been. The guidances from our guideline agencies have suggested that really selecting patients, which we don't have a good way to do so, but to try to select patients that are low bleeding risk and have a high value to prevention of PTS to select them for thrombolysis of a large upper extremity clot. Thrombolysing people does not change the duration of anticoagulation recommendations. So even if you lyse them and clear out the entire clot, they're still signed on for at least 3 months of anticoagulation. In terms of this, generally it's 3 months as per any other DVT, again, extrapolated from lower extremity clot research. But there is an exception in that for people with lines, we generally anticoagulate for longer if the line that caused the clot is still in place. There are newer guidelines, but they have actually not specified for upper extremity clots. So at the moment, that's sort of just the general overview of the upper extremity thrombi. I'm going to talk about a few specific populations because, as mentioned, this does enrich for people that have structural abnormalities and/or cancers with lines, rather than just the random population that develops blood clots due to hospitalization, pneumonia, or just walking in the community with an unprovoked clot. So I'm going to start with talking about thoracic outlet syndrome first, and then we'll talk a little bit about lines and prevention of those types of clots. So there is in our practices, we do see a very young, healthy population in their 20s or late teens that present with major thrombi to their upper extremity. They're generally young people with no past medical history. And in these people, which we have treated as per the guidances above, like with blood thinners, whether that be low molecular weight heparin to warfarin, whether that be DOACs, both have been used recently. These patients typically do get some form of imaging to identify whether or not there is a major structural abnormality causing or provoking this clot. There are compression or injury to the vein that can occur with certain motions in people that have anatomic anomalies or just maybe have very large muscle mass. So these are the investigations that can be done. Generally, the first 4 are done in various contexts, basically to identify any bony abnormalities that can lead to compression of the vein. The CT and MRI are generally what is considered our current standard of investigations. And we haven't ordered an angiogram for a very, very long time. But generally, we're looking for evidence of compression during certain motions of the arm. If there is evidence of this, surgical interventions are possible to correct the anomaly. And in terms of whether that works for this, we can resect first ribs, we can divide bands or adhesions, we can take back the scalene to increase the space available. These are all surgical approaches that are available, and usually we defer to the surgeons as to which is the best option in terms of proceeding forward. In terms of whether that makes a difference, rather than just anticoagulating people or stopping anticoagulation, we do see multiple observational studies suggesting lower rates of recurrent thrombosis and reduced long-term morbidity and swelling if the quotation mark structural anomaly or provoking factor in this population is removed. And because of immobility and from the surgery and surgical trauma increasing your risk of clots, if someone does proceed to a surgical intervention, we do generally continue anticoagulation for at least 3 months past the surgery to allow time for full rehabilitation, mobility, healing, and hopefully a reduction in people's risk of recurrent thrombus in the arm. Occasionally in this population, stents have been inserted. The evidence on this is extremely poor as to what patients it should be used in. Generally, the only summary of this should be that you probably shouldn't insert a vascular venous stent in the arm if there is a structural abnormality, as they are prone to compression or fracturing under the repeated compression at the site. And at this time, there's actually no evidence as to what to do with it once it's in place for a long term, in terms of should we leave people on aspirin, clopidogrel, long-term blood thinners. And these types of large vascular stents do not necessarily behave the same way as the tiny coronary stents. And so we actually are not clear as to what to do with them long term. So I will now chat a little bit about line-associated thrombus, which is the young people, typically the patients that we see as thrombosis in the clinic. This is something that you will likely see in any hospital, just because these are common devices, particularly at the Juravinski Hospital, but again, in many other places to promote vascular access and supportive care. These types of devices can cause or increase in thrombotic risk due to multiple effects. There is a plastic surface that is, technically treated or coated to try and reduce the thrombogenic surface, but it is still a prosthetic material inside your body, which can cause contact activation of the clotting pathway. And alternately, the catheter itself can sort of flop around in there and cause direct endothelial injury to the vein that it's sitting in. And this is particularly important to PICC lines, as they're often inserted in very small veins and can take up a significant portion of the lumen itself, thus obstructing flow and increasing the risk of thrombus. Hypercoagulability due to cancer is a known phenomena, and ultimately the patient that most of these lines outside of chronic IV antibiotics or maybe some TPN is predominantly cancer patients that require chemo that can't be administered peripherally. So this is a very, very high risk population. And as mentioned, so PICC lines are a higher risk device, though much easier to insert than implantable ports in terms of increased risk of clots. So this is one of a common question that we receive and has come up often. The details of the case are not super important, other than that they are a 52-year-old undergoing chemotherapy with a central venous catheter in place, PICC line, presenting with an acute axillary subclavian thrombosis, and they are currently started on dalteparin or low molecular weight heparin at this time. And you receive a question whether or not the PICC line should be removed as a possible infection focus in someone who has fever or other signs of infection. So in terms of this, we had previously mentioned that upper extremity clots should be treated for a minimum of 3 months, plus or minus, until the line is removed. So the answer to this is it depends whether or not that line is still needed for supportive care, et cetera, or whether or not it can be pulled. In this case, I'll just go over this first. In this case, this is the same, and now the cancer agencies and the NCCN have made the same recommendation as ASH and as the ACCP for 3 months of therapy, plus or minus, as long as the line is in. In terms of removing the catheter itself, the summary is in the large text there, is basically if the catheter is working and you need it for various reasons to provide IV antibiotics, to give chemotherapy, and it's fully functioning, you are able to keep it, and you would anticoagulate the patient fully with that in place. If it's not needed, the line is infected, malposition, broken, then it is generally suggested that you should remove the line. And the evidence for this is actually based on 2 studies, both of which are retrospective. And overall, the evidence is unclear, but overall, it seems to be an okay thing to do. The Cancer Center at Dana-Farber has tracked patients to see what would happen to patients that they pulled central venous catheters in. Generally, they did not comment on the timing, but they removed the central venous catheter in 52% of people, likely in short order. which showed no major adverse events in that they didn't provoke any obvious pulmonary emboli shortly after removal of the line. And more recently, this year, a study has come out from Mayo looking at patients. These are specifically blood cancer patients with a persistent line in place, whether or not pulling a central venous catheter within 48 hours of the diagnosis or leaving it in place for longer than 48 hours made a difference in terms of whether or not they responded to anticoagulation therapy, whether or not there were any complications. And what you can see from this graphic, which admittedly may not show up super well because it is somewhat smaller than I thought now that I projected on the screen, is that overall the risk of pulmonary embolism is still very low and does not seem to be affected whether or not you pull the line early or late. Basically, there was no change in the risk of developing a pulmonary embolism if you pull the line, if you leave the line in place. And because this specifically was a cancer population that had a lot of thrombocytopenia, there were many patients that were not able to be anticoagulated because their platelets were 2 or for some other reason. And so this red box does suggest that they actually pulled the catheter and removed the thrombogenic focus in about 116 people with actually 0 pulmonary emboli that resulted in the monitoring period. So this seems to be a reasonable intervention in a population where you are not able to anticoagulate people. I had mentioned these 2 studies earlier in terms of DOAC use, but these are the really only studies that are available that aren't a subgroup of some other larger study. Essentially, catheter 2 was looked at the standard treatment of rivaroxaban, 15 milligrams twice a day for 21 days, and then 20 milligrams thereafter. It had a low recurrence rate at 3 months, so 1.43%. But that recurrence rate included 1 fatal PE, which then made it a little bit questionable in terms of the 95% confidence intervals in terms of mortality, given that it was such a small cohort. That one event made a huge difference. And there was also a fairly large predominance of bleeding events. And when this study was looked at, this tended to happen at the beginning. So when people are on high dose rivaroxaban, the 15 milligrams twice a day, was predominantly when almost all of these bleeding events occurred. So because of this, and hopefully this result will come out in the next soon, but I'm sure COVID has delayed all studies enrollment. The catheter 3 study was a follow-up study to the original one to try and address some of these concerns. They switched to a different direct oral anticoagulant, apixaban in this case, because apixaban is only treated at a high dose for 1 week or 7 days. And generally, our practice has been that we reduce the amount of high dose direct oral anticoagulant by each day that the person is already anticoagulated. And so in this study, they've designed it so that people are treated with low molecular weight heparin at full dose for 7 days, thus removing the person from needing 10 milligrams twice a day of apixaban, followed by apixaban, just the standard 5 milligrams POBID. So hopefully this will provide additional data soon and let us know whether or not we feel confident in using direct oral anticoagulants in this cancer patient population with lines in place. The guidelines still are very conservative, and they do suggest low molecular weight heparin bridge to warfarin, or just maintaining people on low molecular weight heparin. But because many other studies have come out subsequently in cancer patients specifically on the efficacy of using direct oral anticoagulants, more and more of these are being used with relative comfort because there 10-15% of patients in these large trials may have had a central line in place, and there was no obvious signal for adverse outcomes. So while there is not a dedicated study looking at this, increasingly direct oral anticoagulants are used in this population, and generally most people don't have concerns about it. In terms of prevention of generally cancer-associated thrombus and line-associated thrombus, this will sort of lead into sort of my research and recent publications. Low-dose DOACs, so rivaroxaban for Cassini and apixaban for AVERT, have recently been published in prominent journals for prevention of clots in general in high-risk cancer patients. And these were defined as high-risk patients by having a high Karana score. The Karana score being a risk stratification algorithm that looks at people's blood counts, looks at what type of cancer they have, and determines whether or not they would be high risk of developing a blood clot. You know, things like gastric or pancreatic cancer high, things like breast low, things like this. And they just place people for primary prophylaxis on low dose 2.5 milligrams POBID of apixaban or 10 milligrams a day of rivaroxaban. And both studies have shown efficacy of this intervention in preventing clots in cancer patients. And so we propose that perhaps doing this in other high-risk cancer patients would be of benefit. And because the Karana score included a lot of very aggressive malignancies, these tend to be treated as inpatients. And many of these maybe did not get a long-term central venous catheter. And so the types of cancers that get long-term central venous catheters were a bit underrepresented. And so we've decided to investigate this. And I will just sort of present to you some recently published data on this prevention, as well as some hopefully future things. So essentially, the risk of someone developing a blood clot with cancer and a line in place in their arm has been suggested to be about 7%, which we have good evidence that using low dose, low molecular weight heparin prophylaxis can cut that in half to about 3.7%. But overall, this is not done. This is not standard of care. It was never really adopted, even though this evidence has been out there for years and years, just because one, patients do not want to inject themselves daily. It's hard enough to convince people to take other therapies. And two, depending on coverage, low molecular weight heparin is upwards of $20 per day and is extraordinarily expensive. So unless there's a private drug insurance plan, we are in trouble. We chatted about that already. So essentially, a pilot trial was designed basically using rivaroxaban 10 milligrams for 3 months in anyone who has active cancer and a central venous catheter. And we performed it here in Hamilton, not at this hospital per se, because we don't have a ton of cancer patients, but involving the Juravinski, as well as my old center in Ottawa. And really, this pilot trial looked at enrollment rates. So we were trying to prove that we could run a giant randomized control trial across multiple centers across countries that would allow us to obtain funding. So essentially, we looked at enrollment rates. But we did collect all of the data for clinical outcomes, including bleeding, clotting rates, time to catheter failure and when they were removed. And essentially, I am going to just present the data to you here, demonstrating that we were able to enroll 105 patients into this trial, and as such, about 50 or so in each arm, with very, very fast enrollment rates. And when we asked people why they would not want to enroll in this kind of study, it is not unexpected in terms of a cancer patient population of patients that have just been given horrible news. People are already too overwhelmed with all of their cancer appointments and therapy to consider seeing us in the hematology thrombo clinic to discuss this. People are already on anticoagulants for other reasons, or were already taking too many other pills or too many other treatments and didn't want to add or interfere with their therapy, is sort of what came out in our survey. Essentially, the populations, when we looked at this, did enroll what we wanted to, which was like breast and colorectal and other lower risk, quotation marks, lower risk types of cancers, but ones that are often treated with chemotherapy for long periods of time, for many, many months for chemotherapy subsequently, and thus would have a line in place to do that. No great, huge differences. And we did our calculations and sample size for the full-scale trial at needing approximately 1,500 patients. So obviously, not surprising that we're not able to show any major differences at this point in terms of thrombotic complications, but overall, there does not seem to be any major safety concerns in terms of bleeding rates between the two arms. Clotting rates appear to be about the same. But we were able to sort of use this data and propose to this, I don't know, the slide is not worth passing. Yep. We were able to propose to the CIHR using this data that we could enroll, upwards of 7 to 5 to 7 patients per center to enroll in a study like this. And actually, we have actually successfully been funded by CHR to run this exact study with a small protocol amendment. So coming soon to a hospital near you. So hopefully we'll be able to tell you very shortly, and by shortly, I mean in the era, as fast as research moves, which is sort of in like five-year time windows, whether or not giving this to cancer patients with lines is an efficacious intervention. So this is most of what I have to talk to you about, and I'm happy to open this up to questions because this is not well studied, there's lots of gray area in this area of medicine, and I'm happy to take whatever questions you have to see what we can come up with. And or if you have questions later, you can always email me at my email, which is placed here.
We'll just minimize this so that we can see if there are any questions from the Zoom audience. And while we're doing that, wonder if anybody, as it looks like Dr. Holbrook has a question. So you'll say it, and then I'll just repeat it into the microphone for those who are logged in. Okay, so just, I'm not even sure I caught it all because I was doing some technical. Do you want to repeat the question and then answer?
So for the audience not here, so the question being asked is in the young patient population without other comorbidities that is being presenting with, query thoracic outlet syndrome, who's already had imaging ruling out major structural abnormalities, should additional workup be done for other causes, namely, EPO levels or hormone levels if we're concerned that they're doping, should there be other thrombophilias done? There's probably a lot of practice variance between the physicians that are currently in this area just because there's not firm guidance, but having an upper extremity clot does enrich for people with thrombophilias. In terms of those which we care a lot about, so usually for stuff like EPO, testosterone, exogenous steroid use, if there's usually, I'm taking this by careful history, if there's some suspicion thereof, I may test for them, but usually it comes out in the history that, once we discuss that this is a major risk factor, people often disclose that, I have been using supplement X, and we have a conversation about stopping and doing something else. In terms of other types of thrombophilia workup, a lot of the genetic thrombophilias like factor V and such have been becoming, decreasingly important in terms of our stratification because they are not very predictive of subsequent venous thrombosis. They're somewhat predictive of first clots. I personally do screen for ones that would affect my management. So if the anatomical abnormalities are negative, things like antiphospholipid antibody screening are things that I do add before signing off and allowing the patient to hopefully cross their fingers, live the rest of their lives without concern.
And I think Adam's just popped in because it seems like our video isn't transmitting on.
Frozen on.
Okay, if there's a quick fix. While we work on that, any other questions in the room here? I have a question, us being at St. Joe's, which is a nephrology site. I know when I'm on the thrombosis service that's a large proportion of the line-associated clots that we're seeing. Do you have any particular tips in terms of special considerations for that population?
Okay, so specifically to the nephrology population, which often has a dialysis line that's in place basically long-term, unless they happen to be lucky enough to go for a transplant and get a new kidney. This population is quite complicated because predominantly a lot of our anticoagulants depend on renal clearance. specifically DOACs. And as such, this population, we have not been using full dose DOACs for treatment. We have new early evidence using low dose DOACs in nephrology patients with poor kidney function and or on dialysis for atrial fibrillation reasons, or perhaps for prevention of venous thromboembolic events, using like a PIX 2.5 in admittedly small studies thus far. But we have no evidence for treatment of acute thrombus in that population. And as such, the acute treatment often does end up being something like tinzaparin or one of the low molecular weight heparins that we have available, possibly switch to warfarin. Now, this is a problem because no specific guideline has or no study has looked at this patient population specifically, because essentially it's a line that remains in place forever. So ultimately, it's a bit of a judgment call for either considering them for essentially long-term anticoagulation therapy in a patient population that has a very high bleeding complication risk. If you look at studies looking at warfarin in nephrology patients, it is very poor in terms of the number of major bleeding events that we obtain. So it comes down to an individualized assessment, but if it's somebody who is otherwise low risk and it has now been remote from the clot, you may consider stopping in this population. However, if it's somebody who has really no further venous access points, who has failed or has had multiple thrombi, you probably are stuck anticoagulating them indefinitely, whether that be with warfarin or with a long-term low molecular weight heparin at this point. But it's essentially the line stays in most of these patients, and it's a bit of a challenge.
Thanks so much, Rick. And we're kind of squished here at the podium. We got our masks on. Any other questions from the audience before we wrap up? Really appreciate you sharing all of your expertise with us. We're fortunate to have an expert on this topic in-house. Yes. Yep.
I have to look back exactly at the study, but I believe that they were predominantly GI type bleeds. So no major like intracranial catastrophes, but a lot of gastrointestinal bleeding was predominant.
If you want to just repeat what that.
Oh, sorry. Right. The question was, so in catheter 2, now you have to not, catheter 2 study, it was asked, the bleeding rate was noted to be 9 out of 70 patients had some kind of significant bleeding event during the study. Or cohort study, whether or not these were predominantly GI events. To my recollection, these are mostly gastrointestinal bleeds in this study. I'll have to look back to remember exactly the breakdown, but predominantly gastrointestinal is what I recall. Oop, hello? So there's a question regarding the risk-benefit ratio of anticoagulating related to the risk of recurrent thrombosis versus major bleeding in cancer patients specifically. So we know that clots and bleeding are much more common in cancer patients. And in a non-cancer population, we know that per event, 3 times the case fatality rate for a major bleeding event is actually several times higher than a recurrent venous thromboembolic event. So we can't just take it at a 1-to-1 ratio, like, we prevent 5% clots and and then at a cost of 5% bleeding, we'd actually end up probably net negative in terms of overall outcomes. I'm not aware of any specific data suggesting that like the major bleeding event itself has a higher mortality in general, but we can extrapolate that we have good evidence that in general, anyone who has cancer who develops a clotting event in general, so pulmonary embolism DVT, upper extremity DVT, has increased morbidity and mortality in the next 3 to 6 months. Part of that could be that their cancer is terrible and it's provoked the clot, but also by having a clot itself, it often forces us to initiate anticoagulation, and with all of its subsequent complications and major bleeding events subsequently. So it is quite likely that some of the events that cause mortality may actually be due to us in terms of our attempt to anticoagulate somebody for a legit medical disorder, but ending up in serious trouble. I'm not aware of any further data on that, but it would be interesting to know if more cancer patients die from a bleeding event than in other populations. Yep. Yes. Sure. So the question is whether or not there's a role for repeating an ultrasound or some form of imaging at the end of therapy before you decide to stop anticoagulation, or what the plan is in the future. So yes, there is a role. So again, a lot of the data on this is extrapolated from lower extremity clots. The standard really for provoked clots, if someone had COVID, they no longer have COVID and are now healthy in the community, most of the time, we may not do imaging in some patients if we think that the risk of recurrence is extremely low, and if they have no residual symptoms. So definitely, if there's persistent arm swelling, it is useful to know if there's still crud left in the vein, some scar tissue or other leftover chronic thrombus. In terms of whether or not that affects your anticoagulation decision, controversial. If anything, residual vein thrombus has been suggested to be a very weak increased risk for recurrent thrombosis. It's kind of depends on the study you look at. Some say yes, some say no. Overall, it has not been suggested that we should make anticoagulation decisions based on residual vein thrombus. However, having an ultrasound in this population, specifically the younger population or patients that have persistent symptoms, is useful, or in patients that have a high risk of recurrence, namely that you'll have a baseline imaging study to know if their arm swelling is just related to it being hot and they using their arm more often with some venous congestion, or whether or not there's a new thrombus, and also to know whether or not we should proceed with further imaging if there's some kind of concern for structural issue at the time. So yes, there is a role for the imaging, though admittedly more often used as a baseline study rather than affecting whether or not we continue past three months or more for anticoagulation.
All right, I don't see any other questions, either in-house or on the Zoom. So we do have somebody hiding there behind the, yeah, please, come on.
So the question is about whether we would use the same dose of anticoagulants in a very obese or high BMI populations, kind of in the. Are you talking about prophylaxis or prevention? Yep. Right. So we have typically in bariatric populations used weight-adjusted low molecular weight heparin, just because there's such a large variance in terms of dosing or concern. And though it has recently been liberalized, there's been sort of a guidance from the ISTH up until recently not to use direct oral anticoagulants in general for patients that happen to have BMIs that are a lot over 40 or significantly over 120 kilos, though some new evidence is suggesting that it might be okay for AFib patients getting rivaroxaban 20 milligrams. It hasn't come up super often in the cancer population, just because most of the cancer population is not obese. They've generally lost a ton of weight, and we actually end up struggling with the people that are less than 40 kilos in terms of that population. But in terms of prophylaxis in general for prevention of blood clots, maybe not in the primary prophylaxis field, but in people that have had a blood clot, are deemed high risk and need to continue blood thinners long term, it's not based on a lot, but many of us don't dose reduce in that context. So if someone has had a blood clot, many of the studies using DOACs, including Einstein choice for rivaroxaban and the Amplify Extend study for apixaban, have suggested that dose reducing to 10 milligrams of riva or 2.5 milligrams of apixaban twice a day is sufficient for long-term secondary prevention of venous thromboembolism in this sort of a high-risk population that's had a clot already. Though in patients that happen to have a very high body weight, high BMI, or concerns for absorption because they've had a section of their GI tract resected or adjusted in some way, most of us don't dose reduce those patients. We leave them on 20 milligrams, the full dose of rivaroxaban or whatever DOAC long-term, just because we have concerns about drug levels. And outside of, tertiary center, McMaster in Ottawa, it's very difficult to obtain, testing for like rivaroxaban levels, anti-10A level testing, and especially as an outpatient. So we have sort of stuck to the full dose in that context. Most of the bariatric surgery population has its own evidence, and therefore that's why we tend post-bariatric surgery to use the low molecular heparin, specifically tinzaparin, for the time duration thereof. I hope that answers your question, and I'm not rambling.
No, I think that was great. And I love that this has turned into an Ask the Expert about just thrombo and anticoagulation in general. So if there aren't any more questions, then we'll wrap things up for this morning. And again, thank you so much, Rick. And I have to give a little kind of extra shout out to Rick. Due to some fairly last minute rescheduling issues, I reached out to Rick just last week and said, Rick, can you do Thursday rounds? And he said, well, I'm in Brazil right now. But when I get back to my computer, I think I'll be able to pull something together. And you certainly pulled something fabulous together for us this morning. So thank you. And have a great day, everybody. We'll see you back here next Thursday.